really healthy to donate a kidney in the first place?
Yes, that's a very good point. And when you are willing to donate a kidney, you go through an entire psychological and physical, it's like a space shuttle launch. And you know, as I say to people at UCLA, we do about 850, we're talking about living donation now, which is not the cadaveric where you're on a waiting list. So let's say you need a kidney. You bring in 10 people who are willing to donate to you. UCLA in our program will accept maybe 15% of those. So we did I think 858 roughly. My numbers may be off a little bit. We accept maybe 150. And why? Why should that be? Why don't we accept all of them? The simplistic thing is there's no matching. That's what, you know, the lay public would say, but it's much more than that. Many people have things going on in their bodies they have no idea. We don't do CAT scans of our bodies every month to find masses in organ. We don't measure our blood chemistry. I mean, if we did that, we would be picking up a lot of things. Obviously that doesn't occur, but these people go through an entire physical exam that they've never had before. Every organ has to be basically perfect. Plus, a lot of people don't realize things that would affect them, like they smoke or they're overweight. They don't know ahead of time that that might affect the decision. And then there's psychological issues. A lot of people after they donate, not a lot, but some people after they donate a kidney have psychological issues, either immediate or in the long term, or they have already to begin with. All these things we want to prevent. We don't want to do harm. The goal is to do no harm to the donor or the recipient. So some people would say maybe we're draconian, maybe we're too difficult, maybe you know, I'm talking about UCLA per se, maybe it's too difficult to get accepted, and people shop around. They, you know, doctor, I'm going to, you know, forget UCLA, I'm going to hospital X. They're willing to give me one. You know, we try to talk them out of it. We're not doing it because we're trying to be mean. We don't want to create any harm. And so yes, we have a difficult system, but we know with not metaphysical certitude, but with some certainty, that we're doing the best not to harm people. The other is cancer for the recipient. A lot of people can't, on the other side, on the recipient side, who have had cancer can't get the kidney because the drugs that we use to suppress the rejection can bring the cancer back. That's a whole other topic. And so people are upset. You know, I had prostate cancer 4 years ago. Why won't UCLA allow me to get the transplant? So there's certain, you know, guidelines for every single cancer and the drugs they can get, and multiple people part of the decision, not just the nephrologist, but depending on what they have. If it's a heart problem, the cardiologist involved. If it's a cancer problem, the oncologists are involved. It's a whole set of brains saying go, you know, like NASA used to be in the 60s.
Wow. This has been a great conversation. Dan, you have a few more points you want to hit?
Nothing too crazy, but you know, you mentioned before that transplants are taking place a little bit earlier at this stage. And what is the reasoning, or what does that mean exactly?
Right, so the transplant is given at a certain EGFR, and it used to be that we would wait till the EGFR was 10, 11, 12. Now it's being done in some places, not all places, 17, 18, that kind of thing. So people are not waiting quite as long, and that's how they get off the dialysis sooner. It's not a huge difference, but it probably is contributing somewhat to the increased number of transplants. If you look at the curves, every year there's more and more kidney transplants in the US. This year it'll be about 26,000 or so. It's the highest number ever. Total transplants, including, you know, living and cadaveric.
And what is the success rate of, after you've gone through all this rigorous testing?
Right, so it depends if you're talking about cadaveric. It depends how you define success rate, and it depends whether you're talking about a cadaveric or a living kidney. The living kidneys always do better, whether it's even spousal, unrelated. They just do better than cadaveric. The cadaveric is from a person who's deceased. The kidney's sitting around for a period of time until you get the kidney. It's much better to have the two humans right beside each other, take the kidney out of one and put it into the other. There's no downtime. Kidney doesn't go through a lot of different physiologic and biochemical changes because of the lack of blood. As far as the statistics, if you look at the living, we divide it up into 1 year and 5 year survival rates of the kidney and the human. The human is not an issue anymore. It used to be, but the kidney, if it's a living donor at 5 years, 90–95% of those kidneys are working. The cadaveric is in the 80s. It's very hard to get those numbers better. We've got drugs that are optimal now. That's why it's so hard for the pharmaceutical companies to create new drugs. What they don't want is to have to study thousands and thousands of people, spend billions of dollars to get a 1% change. It's just not worth the effort. So there aren't a lot of new drugs. We've got probably the repertoire of the major drugs that are going to keep people at those levels for roughly that length of time. But those are roughly the numbers. So in general, we encourage the living donation.
And what about for the donor themselves? Is that
Right.
virtually 100%?
It's close to 100%. You see all these anecdotal cases of, as I said, there are cases where it's an operation, right? Every operation has a risk. There is a finite risk of having a knife going under the knife that's different from if you didn't. It's tiny, but it's there, and we tell the donors this. Operations have the risk of bleeding. Operations have the risk of getting an infection. There's all these risks. People have to be consented and agree to that. And then in the long term, as I say, there's this still controversy as to whether there's any difference in the long term of that remaining kidney. It's been in the literature for 40 years already. Does that remaining kidney have a greater chance of getting CKD or not? And it's not clear. It might be, and the reason it's not clear is it might occur, but we don't know who it will occur in. It might be people with a certain genetic background. It might be people with a certain set of other diseases like high blood pressure that a donor can get also. A donor may be perfectly fine at the age of 30, but when they turn 50, they start getting obese. They go on some other drug, whatever it is. All these things make everything complicated. You can't track people out for that length of time and assume everything is going to remain the same. You can't do the control experiment. You're looking at large populations with a lot of statistical variability. So it's a hard question that'll probably never be answered. But in general, it's not a risk that would prevent most people from doing it.
You mentioned EGFR moved from 13 maybe to 15 or 16 or whatever. Is that basically because it benefits the patient more because they're healthier and they should get on with the transplant, or is it because, or what was
Benefits the patient. It's if we could transplant people when their EGFR was 25 or 30, it would even be better. People do better with a transplant than when they're on dialysis. There's not even a question.
Right.
Not just physically, but they're happier, they have independence, their life is back to more or less what it used to be. Yes, they have to take the immunosuppressives and other drugs, but in general, people are much happier. People don't like being on dialysis, in general.
At what stage do they have to go on dialysis?
When as I say, when it gets down to about 10, certain things happen. I didn't go into details, but I can. So what happens when your EGFR, what happens when the EGFR gets down to a certain level that forces us to have to undergo what we call renal replacement therapy? This occurs when the EGFR, which refers to the estimated glomerular filtration rate. What does that refer to? Each kidney has 1 million filters. They're called glomeruli, and they each filter water. They filter your blood. A normal person has about 120 liters a day that come through the 2 million filters. That's 62-liter Coke bottles, if you think about it. That's a lot of water is being filtered. You only pee out 1. So your kidney is taking the 119 and absorbing it back into your blood, but it actually filters about 120. That's what your EGFR is. Let's call it 100 just to think of an easy number, 100 liters a day. When it gets down to 10% or 10 liters a day is when we have to do what's called renal replacement therapy. Until then, patients aren't symptomatic, which is sort of one category, how do they feel? And then the other category is what's their blood chemistry. So those two things tend to start becoming abnormal around 10% of normal, which if you think about it, is 5 2-liter Coke bottles filtered a day, 1/10 of what it should be. The symptoms are not what you'd expect. One of the common ones is nausea and loss of appetite. You just don't feel like eating, and you're misdiagnosed as having gastroenteritis or some food poisoning, you went to the wrong restaurant, but this continues, it doesn't go away. So loss of appetite and nausea. The other thing that might happen, I'm not talking about blood chemistry yet, just what would happen is your feet might get swollen because you're retaining fluid. Your blood pressure would go up because you're retaining salt and water. These are the major things that the patient would notice. As far as blood chemistries, we have measurements of what we call electrolytes. These are just different ions in the blood. You might be familiar with them with Gatorade. They're in your blood. So there's sodium, potassium, bicarbonate, calcium, magnesium, chloride. All these chemicals can go out of whack. And so that has to be returned to normal, which would force us. Another thing the kidney does is it controls the amount of calcium in your skeleton. And it does that by making vitamin D. So the vitamin D you get from the pharmacy is not the active form. The kidney turns that pill, when you take vitamin D, into the active form of vitamin D. And when the function gets down to about 10% or more normal, you don't make the active form of vitamin D anymore. And your bones start getting abnormal. The other thing the kidney does is it makes a hormone called erythropoietin. The kidney determines whether you get anemic or not. It tells the bone marrow to make blood. It's sort of a weird system. Why would it be in the kidney? No one really knows. But the kidney makes this hormone. It's called erythropoietin, and it's doing it right now in all of us, and it's telling our bone marrow, which is the factory that makes blood, it's inside our bones, how much blood to make. And when you don't have enough erythropoietin, there's not enough coming to the bones, and you get anemic. And so that's how Amgen became a multi-billion-dollar company, by cloning and making erythropoietin. It's called Epogen. There are newer drugs now where you don't need an injection, but that's what the kidney does too. So anemia is one of the things we see. We see electrolyte abnormalities, we see bone problems, and we see anemia. And all those things force us to say, okay, you need renal replacement therapy, either a transplant or dialysis. So we follow all these things as the kidney function gets worse and worse, and hopefully, if the doctor's any good, they'll have a conversation with the patient about a year and a half before, and go through all the options of what are the choices based on their socioeconomic background, their knowledge of medicine, questions they might have, and together they come up with an approach to what the best way to handle the issue will be when the hand is forced. There are patients who don't want any renal replacement therapy. There are a group of deniers in the United States and elsewhere who don't want a transplant and don't want dialysis and just continue with these abnormalities, hard to treat, but doctor does whatever they can with diet, pills, that kind of thing, and they can go for years. They're not well, but they'd rather not be on the planet and have these kind of things. So there are patients like that.
I told you that was going to be a good answer. That was awesome.
Great answer.